Okay. Now, first of all, just 2 slides about these thyroid diseases. What are the diseases of the thyroid? You are expected to know. And one of the most common diseases is your enlargement of the thyroid. Okay. And this enlargement of the thyroid is known as goiter. So goiter, there are 2 types, diffuse goiter and nodular goiter. Okay. And then this diffuse goiter, there's generalized enlargement of the thyroid gland. That means right lobe, left lobe, as well as your isthmus. The whole gland is enlarged. And there are 2 types. One is the toxic goiter, okay, diffuse toxic goiter or thyrotoxicosis, and the most common of which is called Graves' disease. Then you've got inflammatory goiter, but there's inflammatory changes in the thyroid, usually due to autoimmune, and the most common form of thyroiditis is Hashimoto's thyroiditis. And another group is your endemic goiter, which is not so common these days due to iron deficiency. Okay, so these are the 3 types of diffuse goiters which can be presented to you for examination. Then on the nodular goiter, that means there are nodules. It can be a solitary nodule, which we are going to talk about today. Okay, single nodule, where if in this solitary nodule, the rest of the gland, thyroid gland, is normal. Okay, the other second type is called the multinodular goiter, M and G, which is a very common condition. And in this case, one of the nodules, there are multiple nodules, and one of the nodules becomes more prominent. Rest of the gland is also enlarged, is abnormal. So there are 3 types: simple goiter, thyroid nodule, solitary thyroid nodule, and neoplastic goiter. Neoplastic nodule. So the 3 types of these single nodules. Okay. These are pictures to show you the 3 types. This is a diffuse goiter here. The whole gland is enlarged. 3 types: toxic or non-toxic goiter. Graves' disease is one of them, toxic goiter. Thyroiditis, Hashimoto's thyroiditis, and also endemic goiter, iron deficiency, which is usually a non-toxic type of multinodular goiter. Okay, then here, multinodular goiter, you can see the whole gland is enlarged. Multiple nodules, you can see 2 large on the left side. Maybe there are also smaller ones here, and a large nodule on the right lobe. So these can be either benign, usually they are benign, and most of them are non-toxic. So this is a multinodular goiter. The third category is what we are looking at today, the thyroid nodule, okay, which can be cystic or solid, can be toxic, non-toxic, benign or malignant. Okay, so these are the various things that you lumps that you see here. And here, solitary nodule. Okay, now the next one comes the solitary thyroid nodule proper. Okay, what is definition and what is solitary thyroid nodule? The solitary thyroid nodule is defined as a palpable, discrete swelling within an otherwise apparently normal gland. Okay, it's usually benign in lesion is a benign lesion. There's a solitary nodule. 55% or 50% of patients thought on basis of physical examination to have a solitary nodule, in fact, have multiple nodules when studied on ultrasound. Okay, this is an important fact. Less than 5% of solitary nodules, especially solid nodules, are malignant. Okay, and these are usually due to endemic deficiency type, iodine deficiency. Okay, and then solitary nodules are more common as all thyroid diseases in females, 4 times more, and it increases with age. Okay, so these are important features or factors to facts about solitary thyroid nodule. Okay, here you have got a picture showing you the nodule here, large nodule in the right lobe. Rest of the gland is normal. So this is a solitary thyroid nodule. So solitary thyroid nodule, rest of the thyroid gland is normal. Okay, there's one single dominant, not dominant, dominant nodule, and in this multinodular goiter. Okay, so there are 2 types, solitary and multinodular goiter. In multinodular goiter, rest of the gland is also abnormal, it's nodules. Okay. Now, solitary thyroid nodules, isolated or solitary nodules, account for 70% of the goiters. It's a single lump, non-palpable thyroid. The thyroid is not palpable. Second fact, dominant nodule in a multinodular goiter accounts for 30%. So more common is your isolated or solitary nodule. There's a single lump in a generalized, palpable or enlarged goiter. Okay. What are the causes of solitary thyroid nodule? These are the common causes. Malignancy accounts for 15% of cases. Most common is adenoma, which is a follicular adenoma, which accounts for 30 to 40%. Sometimes thyroid cyst is another important diagnosis. Cause colloid degeneration and thyroiditis. So these are the common causes of solitary thyroid nodule. And the important thing about solitary nodule, why are we highlighting on this importance of solitary thyroid nodule? Because of their malignancy risk. There's a risk of becoming malignant in a solitary nodule. Okay, it depends on number of factors that can be contribute. Solitary nodule is higher incidence. Solid nodule is higher than cyst. Males higher than more risk than females, although females higher incidence of the cancer of the thyroid nodule itself. Very young and very old, extremes of ages. Okay, so in summary, solitary nodules, solid, males, young and old age. So these are the risk factors of the nodule becoming malignant. Okay, and very important, you must suspect after examining the patient, you must be able to suspect whether it's malignant or benign. So features suggestive malignancy will be the lump is hard, it's fixed, history of features of nerve palsy, especially hoarseness of the voice, recurrent laryngeal nerve compression, and cervical lymphadenopathy. When you have any of these features are present, then you suspect it can be a malignant nodule. Okay, so for the solitary thyroid nodule, okay, here we got the solitary thyroid nodule, the swelling and the lump in the neck. 4% in the population incidence. Pain is unusual. Usually no pain, but if there's pain, then it should be due to hemorrhage into the nodule. In a benign nodule, thyroiditis, or more important to suspect, once is the sudden increase in size and pain, then you have to think of malignant change. History of hoarseness due to involvement or pressure on the recurrent laryngeal nerve, more common in malignant cases. And also other risk factors for malignancy, exposure to ionizing radiation, especially in younger, during childhood, family history of thyroid and other malignancies associated with thyroid. Okay, these are pictures to show you the various sites or various ways of presenting thyroid swelling. There's a nodule here, another solitary nodule, one here. This is a very common type of symptom, lower part of the neck. Here, another nodule, one here. Here, there's some changes, skin changes, maybe some form of thyroiditis. And here, nodule, another nodule here. So these are the various types of features that you can see in the patient. Okay, now we come to the evaluation of a patient with solitary thyroid nodule. There are 4 steps as usual. History, very important. Personal history, present, past, and family history, very, very important. Examination, okay. Last week, I already shown you a slide video on examination of a thyroid or neck. Okay, then investigations, laboratory, radiology, and biopsy, and treatment. So I shall go through briefly each one of them. Okay, first history. History is very important. Usually they are young adults, more common in females, extremes of ages. Very young now, it's common. There are 2 peaks. One is in the teenager period. Other one is after the 50s and 60s, older age group. Okay. And usually they present swelling in front of the neck, You have to ask them whether there's any history of pain. Sudden increase in size is a feature suggestive of malignancy. Pressure symptoms such as hoarseness, dysphagia, and dyspnea. And then if it's a toxic nodule, you may have hyperthyroid features. These are the features of hyperthyroidism: loss of weight despite good appetite, CNS symptoms, irritable, insomnia, tremors, muscle weakness, and eye symptoms, which you all, I'm sure by now you're familiar with. So toxic symptoms are very important to determine in these patients. In the history again, history of past neck radiation, especially childhood radiation, family history of thyroid disease and autoimmune disease. These diseases, this type of malignancy, especially medullary carcinoma, they tend to go in families. Okay, the second part, examination. I think I've gone through in detail last week. So first thing, factors to suggest malignancy. The most important thing I said in a solitary nodule, you must make sure it is not malignant, whether it's malignant or not. So usually if they are larger, more than 3 centimeters, they are hard, irregular surface, fixed, and cervical lymphadenopathy. If these features are present, then you must consider them to be malignant. And factors suggesting benign nodule, okay, these are the features. Pain, very important. Pain, tenderness associated with this is usually the lumps are small, soft, smooth, and mobile. So the majority of thyroid nodules are benign. Less than 5% are malignant. In fact, most authors will say only 1 or 2% malignancy. Here again, another picture to show you a thyroid nodule here. Okay, this is a diagram, diagrammatic view here, lower lobe, and these are the 2 types of nodules in the neck. Okay, now we come to the risk factors again. I want to highlight to you, very important. History, age is important. Male sex, history of childhood neck radiation, family history of this papillary thyroid cancer or carcinoma, medullary carcinoma or MEN2, multiple endocrine neoplasia 2. These are in the history you have to get. Physical examination, usually they are large nodules, more than 3, rapid growth, very firm, irregular surface, fixation to structures adjacent, cervical lymphadenopathy, cold, if you do a radioisotoscope scan, is cold nodule on thyroid scan. Then usually they are solid, sometimes also complex cysts on ultrasound. These are the physical examination signs of malignancy. Okay, now what are the differential diagnoses for a patient who comes with a solitary thyroid nodule? First, it can, as very common, it can be a dominant nodule in a multinodular goiter. So multinodular goiter is a differential diagnosis. This must be clearly examined with the lobe, each lobe very in detail, and this can determine other nodules in the thyroid. Thyroid adenoma, usually follicular adenoma, thyroid cyst, thyroid carcinoma, and localized form of thyroiditis. So these are the differential diagnoses for a solitary nodule in the thyroid. Okay, the next one is investigations. Basically, blood test, thyroid function test, TSH, T3, T4. By doing this, you can know whether the patient is hyperthyroid, euthyroid, or hypothyroid. Okay, these are the important things that can decide with your blood test. Then also serum antibodies, especially anti-thyroglobulin, anti-peroxidase to exclude Chiboto's disease or some form of inflammatory disease of the thyroid. Okay, this one to summarize: thyroid function test and autoantibodies, very important blood test. Okay, T3, T4, TSH. You must be able to interpret when the examiner gives you the blood results, to interpret what these results mean. Autoantibodies, if there's family history or if you suspect thyroiditis, then you want to do a autoantibodies. Then under imaging, most important is your ultrasound, neck, ultrasound neck and thyroid. And it's also used for accurate needling in FNAC, okay? Guided, FNAC guided, ultrasound guided FNAC, So this will be the investigation of choice, okay? So three things you must remember. Blood results, lung thyroid function test, ultrasound, and ultrasound guided FNEC. These are the three things that you must do in every patient. Sometimes you want to do a radioisotope scan, especially if it is hyperthyroidism. Okay, you can determine whether the nodule is toxic or non-toxic. Okay, toxic nodules rarely become malignant. Non-toxic nodules will be malignant. Chances are higher. Others, chest X-ray, CT scan, and MRI scan if and when necessary. And core biopsy, sometimes, and very rarely we do core biopsy because of the high risk in doing a core biopsy on the neck. So this will be the imaging. Okay, same thing, modalities. Most important of this is your ultrasound. Okay, very, very, very important. Ultrasound with needle aspiration. Okay. Then again, ultrasound can give you the following answers to your questions. It can determine whether it's a solid or a cystic. Can tell you the size of the nodules. Are there additional nodules in the thyroid gland? Any nodules less than 10 millimeters, rarely you can palpate clinically, unable. Then you got malignant features, which I mentioned just now, the features of malignancy in ultrasound. I'll show you in the next few slides. Hypoechoic, microcalcification, irregular margins, then hypervascular by Doppler. If you do Doppler, you can see very increased vascularity and also lymphadenopathy in the neck. Okay, and this can be also, ultrasound is also a very good guide in doing an FNAC or cyst aspiration. And nowadays they have got this ethanol injection, which I'll talk to you later, and laser therapy, which can localize for you the lesion where you want to use the laser or the injection, ethanol injection. Okay, this is an ultrasound. It's the most sensitive test to detect lesions of the thyroid. Remember, you never, nowadays, ultrasound is a must. Secondly, it's recommended for all patients who have a nodular thyroid. In fact, all thyroid cases, you must do a ultrasound. And you must remember, it is not indicated as a screening test. You don't go to the community and start screening everybody for thyroid, only patients with symptoms. Here are some features to show you. Hyperechogenic, isoechogenic, hypoechogenic. Hypoechogenic, chances of being malignant is higher. And here, mixed, you are unable to detect whether it's hypo or hyper. Okay, this is a benign nodule. You can see here, very well defined hypogenic nodule here. Here, suspicious. See calcifications, and the border is not very clear. Suspicious nodule. This is very important. Here, malignant features on ultrasound. These are the features that you must look for in patients. Hypoechogenic, absence of halo sign. Okay, this is a halo sign, a ring of hypoechosity around the nodule, halo sign. So if halo sign means it's a benign lesion. Then here you see microcalcification and irregular margin. The margin is no borders here. So this is a suspicious of malignancy. Whereas in benign, there can be calcification, but it's called eggshell calcification. Whether eggshell calcification, the wall of the nodule becomes calcified. So this is suggestive of malignant. Whereas here, irregular microcalcifications within the nodule. Okay, so important to realize this. So when you plug a patient with the nodule, try your best to look at the ultrasound findings, so that you can correlate with what you see in your patient. Okay, now we come to this imaging again. The other one I told you, radioactive radionuclide scan, which radium iodine 131 or technetium 99. So you can see hot or cold nodule. Okay, hot means here takes up iodine, so it's a hot nodule, it's a toxic nodule. Cold means it's a non-toxic nodule. And I say chances of malignancy is higher in a cold nodule than a not hot nodule. Radioiodine can also okay, can also reveal show you whether there's any retrosternal extension of the lesion into the thorax. Okay. The third one, family history, very important. Once you have this family history, you must do some markers, serum markers, such as calcitonin, serum calcium, and urinary catecholamines. So these will determine whether it's more for medullary carcinoma, which is usually more of an endocrine type of cancer. Okay. Here, the others include CT scan, MRI. These are usually done, rarely indicated, except if you think if it is malignant, then you want to stage the disease, you want to do a CT scan. PET scan, okay, using this fluorodeoxyglucose F18, okay, and these are quite useful, but most of the time it's very highly expensive and it's only done occasionally, when necessary. Okay, here, FNAC is a very important thing. It gives you the diagnosis. Sensitivity and specificity is 70 to 80%. False negative, 1 to 6%. So it's a very good modality of investigation. But the problem is it depends on the operator. Is operator dependent, and also the depends on the pathologist, the cytopathologist reading the results. Slide. These two are very important. Operator. So if you do not have a very experienced operator or a cytopathologist, then your results will not be that good. So once you have this, it can be either malignant, positive, or it can be suspicious, indeterminate, or benign. Okay, I'll go through this in a short while. Okay, this is a picture you must remember. Ultrasound scan under ultrasound. This is the probe, ultrasound probe, patient lying supine here with the neck here. And okay, here the probe, the ultrasound probe is here, the nodule is here, and then the needle is used to aspirate the contents or tissues from the nodule. Okay, this is how you do that. So this is a ultrasound scan, ultrasound, FNAC under ultrasound guidance. Very, very important, you must know. Then you get the result that you can see. All right. So ultrasound is a very good instrument to localize the lesion for you to accurately get your tissues. All right. Then once you have this ultrasound done, under FNAC done, the classification, the result is most commonly used is your Bethesda classification of thyroid nodule fine needle aspiration. Okay, this is a third type of classification from 1 to 6. Okay, now 1 and 2 benign. Actually, 1 is unsatisfactory, so you may have to repeat the aspiration, and 2 is benign. So once it's benign, no surgery. So maybe you just treat them conservatively. The other group is 5 and 6, they are malignant. 6 is definitely malignant. This is highly suspicious of malignancy. So in this patient, they may need further surgical treatment. Okay, lobectomy or total thyroidectomy in these patients. Okay. The third group, this is very commonly encountered, is known as the undetermined group, where 3 and 4, you are not sure whether they fall into malignant or benign. So this is the undetermined group. So in these patients, we have to consider other forms of investigation to decide whether it is malignant or not. Okay, you have got here the result, routine FNAC, can benign, no problem observation. Malignant, surgery, very important. There's a big group now, especially follicular adenomas, whether they invade you cannot diagnose on FNAC alone because you don't know whether it's invading. Only by knowing it is invading the tissues, then capsule, then you will know it is malignant. So this one you cannot, indeterminate. So in this, there are a number of tests that can be done these days. One of the most commonly done is some genetic sequencing, which is known as thyroid sequencing, which is actually a test that uses the collected cells from your FNAC to analyze the DNA and RNA. So you look the sequence of the RNA and DNA in the cells, and that will decide whether it's benign or malignant. This is quite accurate. It's done in US, I think quite often is done, but it's very expensive. If it is negative, then you know the cancer possibility is less than 5%, so you observe the patient. If it is positive, then you proceed with surgery. Okay, this is known as the thyroid sequencing. Okay, now some people also do this immunohistochemical markers. Okay, it's not routinely done. I just put there for you to for your knowledge. Two important types of the HBME1. Okay, it's a monoclonal antibody and stains the papillary cancer cells, so you can detect. Biopsy, if the stains, the cells are stained, that means it is a malignancy. All right, and then the other thing that they use is detection of galectin-3. Yeah, so these are very highly sophisticated. It's not done in most places. Then you've got thyroglobulin and thyroid transcription factor for follicular cells, calcitonin, CEA, and chromogranin for C cells, parafollicular cells. So these are the two types you can use. So these are histochemical tests, immunohistochemical tests, which are nowadays done in many big centers. Then come to the last one, treatment, benign, and medical. Usually some people have tried using high dose of thyroxine, give them thyroxine to suppress the growth of the tissue, nodule, right? To keep the TSH low, so the nodule will not grow. But this is not widely used because the so-called TSA suppression therapy may have side effects. If you give high dose, patient becomes thyrotoxic. The other important treatment is surgery. Surgery for indications FNAC positive, clinically suspicious, especially elderly, male, hard texture, fixed, recurrent laryngeal, all the features which I mentioned on for malignancy. Cosmetic reason is too big and unsightly for the patient. The toxic nodule is toxic, or it causes pressure symptoms. Okay, once these indications are there, then you go for surgery, which can be a lobectomy or isthmusectomy or total thyroidectomy. This is a hemithyroidectomy. This is a total thyroidectomy. Okay. Then you have other forms of treatment, radioiodine and percutaneous ethanol injection and laser photocoagulation. Okay, if the tumor is benign, then you can go for this type of treatment to ablate or destroy these nodules. Okay, this slide summarizes management, confirm the diagnosis by thyroid function test, ultrasound, and ultrasound FNAC. So these three things you must do. Before that, of course, you got your triple assessment, clinical, history, and physical examination. Once you confirm it's benign, then you can either observe the patient if the nodule is small, or you can proceed if it is big, then you can go for lobectomy. Okay, hemithyroidectomy. If it's a cyst, can aspirate. If it's a solid, most of the time, chances of malignancy later can be higher. So if the patient is fit, you go for surgery. If it's benign, nowadays they have got non-surgical procedures, percutaneous ethanol injection into the thyroid, into the nodule, or laser photocoagulation of the nodule. These are done under ultrasound guidance. So these are much simpler procedures, and you must make sure they are benign before you can subject the patient to this treatment. The second group is your malignant nodules, straight away surgery in the form of either lobectomy or total thyroidectomy with lymph node dissection is the most important treatment. And for this, you may have to do a CT scan, chest X-ray to stage the disease. If it is toxic, then you do medical treatment, TSH suppression with thyroxine as a radioiodine. Okay, so this will be your important to summarize your treatment. And these pictures here show you here CT scan of the thyroid. This is anaplastic cancer. This is a benign cancer here. Sorry, a benign nodule here. There's calcification, eggshell calcification. And here's a papillary carcinoma in the left lobe. Okay, this one shows you finally the flow chart, how you say solitary thyroid nodule for the cyst, aspirate the cyst, and follow up. So cysts are usually benign. So you do a ultrasound and thyroid function test, you get a solid lump, you go for FNAC. Benign, you go for either observe the patient or do a local lobectomy or hemithyroidectomy. If it is malignant, you have to go for total thyroidectomy and other treatment, radioactive ablation, TSA suppression, and completion thyroidectomy. Yeah? So these are the things that you go for. Now, the other big group I said is your indeterminate. So in this indeterminate, you subject the patient to a thyroid sequencing. Yeah? And this thyroid sequencing, I told you, uses the next generation sequencing technique. It's a new technique where they can analyze the cancer genetic sequence, DNA sequence of DNA molecules in the cell. That will tell you whether it is malignant or benign. If it is malignant, then there's no problem. You could treat the patient with total thyroidectomy and other treatment here. Okay. The other chemical thing that it shows is, which I mentioned earlier, immunohistochemical, HbMe, and keratin 3. Okay. So these are other forms of tests to determine whether the nodule is malignant or benign. Okay. The other one is your THH, thyroid, TGH, thyroglobulin markers, thyroid transcription, and for the follicular cells. For the parafollicular cell, for medullary carcinoma, you can use calcitonin, CEA, and chromograin for the diagnosis of medullary carcinoma. Okay, finally, these are the features, key points. Solitary thyroid nodule, palpable discrete nodule within an otherwise normal gland. Usually a benign lesion, okay, and you must be familiar with the features of malignancy. 50% of what you think is solid is actually multinodular, and this can be confirmed on ultrasound. Solidosis is very important because solid is very chance of, although it's less than 5%, but it is a possibility of malignancy. Right? Actually, it's quite prevalent, quite common in our society, the thyroid nodules. The important thing will be to summarize the important things I mentioned just now. Malignancy, most important, as far as your exam is concerned, they would want to know what are your features or to suggest if patients the nodule is malignant or benign. Okay, mark hypogenicity, and the ultrasound is the best method. Mark hypogenicity, infiltrative, lobulated margins. The margins are not very clear. Microcalcification, and on ultrasound, a taller than white shape on transverse view. Okay, so these are the features you must look for in your ultrasound to decide whether they are malignant or benign. So systemic ultrasound examination supplemented by history and examination to decide on FNAC. Okay, very important. So systemic ultrasound examination must be supplemented by history and clinical examination. All right. So you need a good quality ultrasound, which is available in most centers these days, and compression features and cosmetic issues are the indications for surgery, other than malignancy. Okay, thank you.